And our presentation today is about how to accelerate ROI using FTI Catalyst. That's what FTI Catalyst was designed for. FTI Catalyst is a quick win kickstart for healthcare analytics that will get you up to speed and into ROI faster than any comparable dashboard. So how did future technologies come to develop this type of solution? FTI has been delivering system integration solutions for over 16 years. So we are experts in data management, system integration, business intelligence. Not only can we provide implementation, migration, architecture, and database upgrades, but we deliver a complete solution. So should you require data integration, warehouse design or redesign, we've done that. Ad hoc reporting, OLAP cube or scorecarding, we've done all that using a proven maturity model. And we noticed the need in healthcare for that type of quick win solution, so we applied our expertise in data management to building the FTI Catalyst, which is it's a dashboard set for healthcare built using our expertise in solutions and Dan Gerena's vast experience in healthcare. So Dan Gerena is our product manager. He's a former BI and analytics director for a major New York hospital system. Dan spent over 13 years with a team of around 4 additional to develop FTI Catalyst. And so instead of requiring the months and if not years and teams and iterations that these projects typically demand, Dan and his team put together a core set of metrics that will start creating operational improvements and cost reductions in the shortest time possible using a pre-developed, predefined data model from his experience. So Dan's organization went from about 60 million loss to a large profit due in part to their enhanced ability to measure and monitor their results and hold everyone accountable. So that's my quick snapshot, and I'd like to turn it over now to Dan Gerena, our product manager.
Thanks, Ben. I worked for a healthcare organization called Kaleida Health. I don't know if you're familiar with us, but we're the largest healthcare system in Buffalo, New York. 4 adult acute hospitals, 1 pediatric hospital, about 62,000 discharges a year, about 1.4 billion in revenue. So we're large in this area here. And so I started at Kaleida about 14 years ago or so before joining FTI, and at that point we had literally nothing in terms of reporting. Like I literally would stuff paper reports into interoffice envelopes. That's how we used to, disseminate information when I started there. So over the course of my 13 years at Kaleida, effectively what we did was develop a strategy around. And we started small and iterative, right? But we developed a strategy around what data do we want to attack first, and we developed a data model that would allow us to incorporate additional metrics over time. So we started out first with financial metrics and understanding our labor, for instance. So your labor is going to be the largest portion of your expense. And so we focused on overtime utilization, unscheduled time off, a lot of focus on the staffing, the traditional staffing metrics such as turnover rate, time to fill, things of that nature. And then once we solved those problems, we moved on to our revenue and billing issues. So we focused on accounts receivable, and then we evolved slowly over into the clinical side and focused on discharge management, length of stay, resource utilization. And when all was said and done, effectively what we did at Kaleida was we had every major and minor system feeding into our data model. So we could answer questions not just from a siloed approach of, what were our discharges last month, but which patients were profitable, which ones weren't, why were the ones that were profitable, and why were the ones that weren't, focusing on outcomes as well, coupled with that information in terms of complications and mortality rate and readmissions. And so traditionally what a lot of organizations do is they start with a single focus area. And they, over time, gradually, iteratively expand the scope of that, because all of these metrics really are connected, right? Your readmissions affect your finances, even though you may consider it a quality metric. Your length of stay affects your finances, right? Everything is really interrelated, and it's becoming more so because that's how you're being incentivized going forward. And so really you have to focus on not only financial aspects, but operationally, how are you effective and where do you have opportunities to improve, and also on your resource utilization side in terms of labor utilization and you know, what stents are you using, and which physicians are using more than others, and imaging tests and that sort of thing. So when I joined FTI about a year ago, really what we wanted to do was build essentially a shortcut. With all of the learnings that I've had over doing this over 13 years at a large healthcare organization, I wanted to leverage all of that expertise and build a predefined data model. So on your screen there, let me just give you sort of a 50,000-foot view of what Catalyst is. You've got data in various disparate systems, right? At Kaleido, we had Cerner as our EMR system. We had Eclipsys as our billing and revenue system. We had Lawson as our ERP system. And we had Kronos as our time and attendance system. So we have all these different systems, right? And there's really good, valuable data in all of them. But you can only maximize the usefulness of them if you get them all in one spot. And so what we did was we predefined a data model. We took all of the expertise that and the learnings we've had over the last 13 years and said, okay, what are the key attributes that we need? What are the metrics that we need to compute? And what are the inputs that go into all of those? So we have a predefined data model. On top of that predefined data model is a layer it's called the metadata layer, essentially. It's all the joins and relationships between those tables, all the math in terms of calculations. You know, when you do, for instance, profitability, it's direct costs minus payments, and all the drill hierarchies. I want to go from hospital down to you know, department down to nursing unit, etc. So that layer there is sort of the logic that sort of glues all of the pieces together. And then what I'm going to jump into in a second is the actual dashboards, how your users will actually consume the information. So really, when I started, we had none of this defined. We had source systems, right, and like you have source systems, but we really didn't know where to start, how to integrate it. And so what we're doing is leveraging the expertise of actually having done this in a large healthcare organization and being sort of in the position where I could tweak it and refine it over time and figure out what works, what doesn't, what attributes would add more value, etc. So we package all of that into Catalyst, and then we built a set of dashboards on top of it that's also pre-built that essentially use visual best practices and are more intended so your users can sort of have a mechanism which is more of a guided analytics tool. It's not saying your length of stay was 4, but it's the ability to drill down and understand why and slice it and dice it in various ways. So really, what we're really trying to do is offer healthcare organizations a jump start. So we just recently implemented at Hackensack University. Okay. And so in the span of between 90 and 120 days, what I'm about to show you is now implemented there. Okay. And the beauty of this is, as you're well aware, investments in technology and you know, they're very expensive. Databases, right? You've got to hire a DBA. You've got to buy a BI tool set. You've got to have a tool that moves the data from A to B, all of that. And then you have to educate your users, et cetera. So it's a very costly undertaking that really, if you take the approach of I'm going to build it slowly and iteratively, it will take you a long time to get that return on that investment. So what we're really offering here is a predefined, pre-built solution that gets you rapidly to a balanced scorecard approach, and then the focus becomes, okay, what can we focus on now to ask more strategic and analytic questions and more sophisticated questions, and that we want to incorporate additional data into this data model. So an important attribute of this data model is that even though it's predefined, you're not locked into it. You fully own the data model. So as we implemented in Hackensack, they now, let's say for instance at Hackensack they have a bariatric center of excellence, right? And they want to capture BMI, body mass index, in that data model. They can add whatever attributes they want to add over time. They can add additional tables into the data model. So let's say they wanted to focus on patient satisfaction, and they do Press-Ganey reports. They can incorporate that data into the data model and now link it to the data model. So now they can answer questions that they've never, been able to ask because the data was sort of living in a siloed approach. So now they can look at a patient satisfaction score for a particular physician and say, well, what's that physician's profitability? What's that physician's complication rate? What's that physician's readmission rate? And so now you can tether all of these distinct things together in a single data model and answer really sophisticated questions that, if you start from scratch, it's going to take you a long time to get there. So that's really the value-add proposition of Catalyst, is it's a rapid way to get to sort of a best practice approach. What took us 13 years at Kaleida Health, Hackensack is there in under 120 days. You know what I mean? Because they didn't have to start from scratch. Effectively, the work that we had to do with Hackensack was, well, what are your source systems? And based on that, we work with them to map the data from the relevant source systems to our data model. Once we do that, everything else is built. The dashboards are already predefined and pre-built, and the metadata layer where all the joins of relationships and calculations exist, that's all pre-built as well. So if that makes sense, that's really what we're talking about here is really, instead of going from A to Z, only the need to go from A to C, which is just moving your data to the data model, and D through Z is already predefined and pre-built. But the beauty of it, though, is as your organization evolves over time, as the needs change, let's say you add additional hospitals, you add more clinics, you have different focus 2 years from now that you don't have today, the data model, the dashboards, that's all under your purview. You can add additional tables and fields to it. You can create your own set of dashboards. So even though we're coming in with a pre-built solution, you're not locked into it. So we have a balanced scorecard approach. So the ability of not starting small is you can have a launch within your organization where key stakeholders from across the organization are invested in the tool immediately. So not only are you getting a rapid return on your investment, but you're really getting that critical mass of folks across the organization who you need to be accountable for results. So we have financial dashboards and hospital presidents and CFO and folks like that, chief operating officers. They're going to be focused on that. But also we have operational metrics focused on length of stay and patient throughput, room utilization. So the same audience is going to also have an interest in that sort of information. But again, now we're broadening the audience for the tool as well because now nursing managers need to focus on certain things like length of stay and discharge management, that sort of stuff. Quality metrics, mortality rate, complication rate, readmission rate. Naturally, your quality directors and chief nursing officers care about this information, but it also has a financial implication, right? Staffing dashboards focused on payroll, overtime utilization, a lot of focus really on the labor component of your expenses. And we've just built out a new module around emergency departments. So if you have an ED, you're aware that the majority of your admissions, or at least probably about half of your admissions, probably are driven through volume via the ED. And so we focus on throughput in the ED and what's driving admissions through the ED, how your respective physicians in the ED comparing to each other in terms of throughput and the types of patients they're seeing. So we capture a lot of elements as far as arrival time, how long does it take from arrival to triage, to when they go into an ED room, to when the doctor walks in and speaks to them, to when the doctor either orders an admission or gives them instructions and the patient gets checked out as an outpatient, sent home or wherever they may be sent from that point forward. So a lot of focus. It's sort of a deep domain dashboard focused on emergency department. And so that won't be in the live demo today because we're putting the bow on that. That'll be ready in about 2 weeks or so. But I just wanted to make you aware that we also have a fifth module here around, in terms of content around the emergency department and, looking at frequent flyers, looking at patients who expire in the ED, and the ability for your users to not only see that information, but to drill down and understand what the drivers are of all of that, those key metrics. So Aside from that, just touch on briefly before I jump into the actual demo, we have a set of financial dashboards focused on profitability, case mix, payer mix. So when you think in terms of why am I making money or why am I not making money, there are drivers on the revenue side, and on the revenue side you have your payer mix. You know, are your patients Medicare patients? Are they commercial patients? So we take a look at the payer mix information, the case mix acuity. So if you've increased your orthopedic surgeries for the quarter, but you're doing more elbows than hips, it's not necessarily going to have the same impact as if you were doing more hips than elbows. We focus a lot on the top line aspect of profitability, as well as the bottom line aspect of profitability, your expenses. So is length of stay creeping upwards, thus your costs are going to increase. We look at charge utilization. Are you using more x-rays on average per patient than you should be? Those types of questions are answered in Catalyst. We focus on quality in terms of mortality rate, readmission, patient complications. And finally, we focus on the staffing aspects, such as overtime utilization, trends in payroll activity, turnover rate, unscheduled time off, that sort of thing. Here on the screen you see just an example of our data model, just a small piece. But you'll notice this is at the encounter level. At the encounter level, we're capturing demographic information. So for instance, where's the patient reside, what's their zip code, what's their age, their gender, race, language, etc. We capture clinical information such as if they're an inpatient, the DRG, if it's an outpatient, was a procedure performed and what's the principal procedure number. Then we capture physician information. So on your clinic patients, for instance, who those particular, who is the attending, the referring. So as you get patients, for instance, that get referred from your outpatient clinics to an actual as an inpatient, right? So let's say you have an ortho clinic, right? And you have a number of physicians on your outpatient ortho clinic, and then that naturally, as you would expect over time, should drive inpatient admissions, right? So on every encounter, inpatient or outpatient, as long as you capture those attributes at the time of registration for those patients, so we have slots for who is the primary care physician, who is the attending, who is the admitting physician, who is the referring physician, what was the admit referral source, and on the outpatient side there's the equivalent. So as long as in the registration process you're capturing those attributes, there's a spot in the data model for them. So the big question really is, when you go through your registration process in your outpatient areas in your family health clinics, it often drives whenever this data, the beauty of this data model is it very quickly allows this information to become visible and people start relying on it to make decisions. And what will naturally inherently happen is as data becomes more visible, things start, all of a sudden, magically, there's a focus on getting the data clean, getting it usable. And so even if today you're capturing it and it's not quite matching up to, maybe you have a physician master and you're not putting it in the same way in two different systems, et cetera, that all magically works itself out because now the data has become more visible and those types of priorities escalate. So as long as you're capturing the information, we can absolutely present it in the dashboards and you can track referral patterns, things of that nature. The challenge most of the time, especially with a smaller healthcare organization, is how well you're capturing it, and do you have a process around capturing it. But assuming you're capturing it, yes, absolutely, you can do reporting and dashboards on all of that information. So even though what I'm going to demo today, for instance, when we look at profitability, and I'm going to pick maybe a cardiac or an orthopedic inpatient product line, the data model is set up. There's a field in this table for the type of stay, inpatient versus outpatient, and there's a more granular one, so you can segment your outpatients into family health clinic versus ED outpatient versus ambulatory surgery patients, etc. So there's a lot of leverage baked into the data model already to assume that whatever problems we solved at Kaleida Health, you're probably going to have the same needs. And so if it works for us, it's certainly going to be able to work for you. But the beauty of it also is the data model is fully customizable. So if we want to capture new attributes, we can just add them to what we capture. What I'll do is I'll jump into the demo. So it's really a balanced scorecard approach, financial metrics, operational metrics, quality metrics, staffing metrics. So when we implemented this at Hackensack, this content map is exactly what the users see, and now the content is sort of makes sense to them in terms of where it lives, where it resides, and all they need to do is click on any of those boxes and they jump right to that dashboard. So what I'm going to do is show you one or two dashboards, and then we'll see if you have any questions in terms of specific content. We have a lot of content in here, but what I want to do is first off focus on the highly functioning dashboards that we built and how they're set up. So a lot of organizations, when they develop dashboards and they roll them out, they wind up having various flavors of every report. I've spoken with hospitals. I say, do you have profitability report? And they say yes. And I say, do you have one dashboard? And they say no. We have about 70 different versions of profitability reports. Well, what that means is that takes a lot of resources to maintain and manage all of that. So our methodology instead is to build all the flexibility in that user layer. So a lot of parameterization, for instance, where the user comes in here and there's only one profitability by product line dashboard regardless of who the user is, right? So they come in and they say, what's the date range you want to look at? Is if you have multiple hospitals or multiple nursing units or multiple clinics, you can pick and choose those. If you want to pick certain slices of the organization, for instance, orthopedic surgical patients, even down to the individual physicians. And again, all the layers are fully customizable. So if you say, I want to add nursing unit as an option, for instance, discharge nursing unit or whatever the case may be, you can add that as well. So we built a lot of functionality in terms of parameterization, but you'll also notice as we look at this information that there are layers behind. When you land on this particular dashboard, you see a scatter plot showing profitability by patients, but behind that there are layers, right? And so let's say I didn't want to see the individual patients in a sort of a scatter plot, but instead I want to see a summary of the individual DRGs that comprise orthopedic surgical product line. Now I can see across hospitals, and again, this could be across nursing units, could be across however you want to define it. But out of the box, we've got across hospitals, I can see what my volume is and my aggregate profitability across the DRGs that comprise orthopedic surgical, right? So I can see they do a lot of spinal fusions at this hospital and hardly any here, but this is more balanced in terms of the major joint replacement, that sort of thing. And so now I can have a comparison of volume and profitability across entities, that sort of thing. So the intent here is to make you aware that when I show you this information, bear in mind there are layers behind it where your users will come in and based on who they are and what their role is in the organization, they may want to see it slightly different. So the beauty of this is not to have them ask you to do it in a different way, but we have all those predefined layers built already so they can interact with the information immediately when they're looking to analyze it. So let's talk about content for a second. So here we have a scatter plot, and I have a dot for every patient, and I'm not necessarily concerned about all of the cluster of dots in the center here, right? I'm more so concerned about the outliers. This particular patient, we had $78,000 in gross charges, yet we still lost about $7,500 in margin on that particular patient. So your users have the ability to drill down to the patient level. So I was at the 50,000-foot view where for a 4-month period, I was looking at all my orthopedic surgical patients across hospitals. And now with one click, I'm looking at a specific outlier. And I'm seeing who that patient is, who is their physician, what was their length of stay. Any attributes you want to add, they're all captured in the data model. So it's fully flexible and customizable. But right out of the box, you can see in terms of profitability, I can look at profitability a number of ways, by hospital, by product line, and very quickly get down to the patient level detail, look at it by DRG. Over to the right, I have net aggregate profitability broken out by hospital by month, so I can see how my profits are trending over time, and below that, the volume behind those cases, the volume behind those dollars above. And then finally, over on the bottom left here, I have the bottom 10 patients in terms of profitability. So when someone lands on this dashboard and they say, I want to see cardiac medicine for hospital A, they have these 4 views, and plus the views behind these views, already sitting there waiting for them to consume the information. So every time they land on this page, they can see who the least profitable patients were, and naturally they can drill on those and look at additional information about those patients. Who is the doctor? What was the length of stay? What insurance did the patient have? All of the relevant questions that come up from there. And there's also the ability, when you look at this information, I'm looking at the 10 least profitable patients. I can just sort any of this stuff in place. So with one click here, I'm now sorting descending. So now I'm sorting, and I'm looking at the 10 most profitable patients in my orthopedic surgical product line for whatever date range I specified. So a recurring theme with how we build this is really focused on the user and how they're going to consume the information, and what are the next questions they're going to ask when they start looking at the 50,000-foot view and trying to understand why something's happening. What are the trends? What are the outliers? What are the root causes for those outliers being outliers? And all of that functionality is built in to the Catalyst tool. So this is just one dashboard of 21, for instance, but I just wanted to walk you through it to show you the functionality as well as what the mindset was behind it when we built it. So what we're really trying to do here is very quickly implement the Holy Grail. The Holy Grail of business intelligence is a balanced scorecard approach. A lot of organizations, they start small, they start slow, and it's really because it's a resource issue, right? It's really, okay, we have to pick somewhere to start, and I have, 3 BI staff, or I have 5 BI staff, or I have 1 BI staff who's doing it part-time. Whatever the case may be, the challenge is, okay, where do we start? How do we start? So the intent of this is to have all of these dashboards up and running immediately, so now you can focus on supporting users as they use it, educating them, building out new content, etc. So we're on the financial dashboard, a lot of information around naturally financial. Instead of looking at the patient encounter level, on every encounter, if you remember that slide I showed you where at the encounter level we capture all this information, right? Financial class, gender, age, demographics, all the physicians on the case, right? So in theory, I can create a profitability dashboard using any of those attributes, right? So this particular dashboard is looking at it from a physician perspective. So I can see, for instance, Dr. Gene Crabtree had 81 cases and $2.7 million in total charges. What were the payments on those 81 cases? What were the direct costs on those cases? What was the net profitability? So even though she by far has the most in terms of total charges, you can see her profitability per case is the lowest, right? So naturally I can drill on her cases and see those 81 patients and drill further and understand that. So the intent of the profitability dashboard from the physician perspective, right, is to understand, so these are Dr. Crabtree's 81 patients or whatever it was, right? And so the intent is to really to understand from a high level, which physicians are bringing in the volume, which physicians, which of that volume is translating into actual revenue, right? So let's say, for instance, you're looking at, you have a scarce resource in your hospital of operating rooms, right? And you have to make decisions as to which physicians you give time and which ones you don't, right? So if you don't have ready data accessible in terms of the types of cases they're bringing in the door and how profitable those cases are by physician, how do you make a decision in terms of who you allocate time to and who you don't, right?
Right.
And further, when you start peeling back the onion, it's valuable to understand not only why that Gene Crabtree is your least profitable per patient, but you can also drill down and understand why. Is her length of stay higher, right? So are her patients staying 7 days instead of the average of 4.4 days? Is she doing more x-rays than her counterparts on her orthopedic hip patients? Does she have more Medicaid patients than Blue Cross patients, right? So maybe a payer mix issue. So there are a number of myriad drivers that drive whether or not one physician is more profitable than the other. So the beauty of a comprehensive data model is you can start asking all those questions by just clicking on the data. Okay, so this is an example of profitability by physician, and below that we go one step further, which is for every physician in our data model we have a physician master table that associates a physician to a physician group. So you have independent physicians, you may have hospitalists, but then you have physicians that are part of a group, right? So you may have Hudson Valley Orthopedics, right? Well, how much, I'm making that up, maybe that's a real one, I don't know, but how much, how much profitability does that group bring in versus, Niagara Mohawk Orthopedics, that sort of thing. So the ability to stratify any of these metrics by different attributes is pre-built into the Catalyst data model. So you don't, even though we're talking right now about profitability, you can look at the same thing by physician or by physician group for readmissions, right? You can say, does this particular group have a higher readmissions rate than this particular physician group, right? You can look at complications. If you were to bring in, if you were to look at length of stay, right, you can look at length of stay by physician group. So the permutations are almost immeasurable, right? And the intent of that is not that you want to see everything every possible way, but when you start drilling into the information and understanding what the drivers are of your particular issues, why am I not making a profit on this type of patient, your reasons may be different than Kaleida Health's reasons, right? You may have an issue with discharging your patients, and you have a high length of stay, so now in your data model you have the ability to make that a focus and build dashboards around that, if they're not already built, but we have an extensive set of length of stay dashboards. But you have the ability to say, okay, this is what our focus needs to be to change behavior, to change protocols, to change procedures in order to reduce the length of stay. So what I'm going to do here is I'll just jump to an example of, I'll go back to my main landing page. And let's say everybody loves readmissions, right? So we can look at inpatient readmissions, for instance. So I have a dashboard built around inpatient readmissions. So even though traditionally it's a quality metric, it also now has financial implications for you. So everybody cares about readmissions now. So when we did readmissions, what we've got built into our that metadata layer that I mentioned is the ability to look at patients, and every patient has a medical record number that's associated with them. So we've built logic into our metadata layer that says, okay, find me all the patients who are the same person, line them up, and let's say I just want to see 30-day readmissions. That's what this particular dashboard is showing me. So I have the ability to specify a date window, and if I want to make it 7-day admissions or 60-day admissions, I can do that as well. By default, I'm looking at 30-day readmissions. So for my two hospitals, for instance, I can compare them, their respective 30-day readmission rates to each other. And the beauty of it is naturally these 266 patients out of these 8,700 patients were readmitted. So naturally, I can click on that and see the readmissions. And I can see what the first discharge was, what the second discharge was, who the physician was on the first and the second discharge, what was the DRG on the first and second discharge. So now you can see, this longitudinal perspective of the data where you can see across the two encounters for a particular individual and try to understand readmissions a bit better and what's driving that. So not just purely, okay, here's your readmission rate, but the ability to understand why your rate is what your rate is. In the middle here, is a bit of a unique view of your readmissions. This is a histogram, so I have a bar for every day. So this essentially tells me of these 380 patients, the majority of them, 54 of those patients, were readmitted within 24 hours, right? So on day 0. So within 24 hours of the initial discharge, 54 patients were readmitted. So naturally, I can drill down and see those 54 patients and understand who they are, who are their physicians on the cases, what were the nursing units that discharged them, and then I could sort of reverse engineer and understand, okay, are we not giving good discharge instructions? Are we not making sure that someone's there for the patient when they get discharged to help them take their medication or whatever the case may be? Are these patients being discharged to a skilled nursing facility? Are they being discharged home? Are they being discharged home with services? So we have a very deep and robust data model, and so now you can start asking very sophisticated questions quickly about any subject matter, but this is an example using readmissions of how I can use that sort of information to understand what's going on and more importantly, what's driving it. And then finally, here's another unique way in which we look at readmissions. So let's say, for instance, Dan Gerena was initially discharged for an ear, nose, throat issue, and then he got readmitted within 30 days, 13 days later, for instance, but for a vascular surgery issue. So the two are probably not related, right? So what we're really looking for is of all your readmissions, there are certain ones that you can actually do something about, right, and adjust that curve, and certain ones that, they're really unrelated. And so what we're doing here is sort of doing a matrix of, well, what was the current discharge reason versus the initial discharge reason? And so naturally, I'm more concerned with these 7 patients who are here for a vascular surgery issue and then got readmitted again for a vascular surgery issue, right? So it's trying to suppress the false positives and focus on the actual areas where you can actually make a difference if you change processes and protocols and procedures. So I'm running short on time here. There are 19 other dashboards, 19 other subject areas. But effectively, what I wanted to convey to you today was the functionality of it in terms of, how your users will use it, and with the ability, to drill down and to ask more sophisticated questions. So there's the usability as well as the breadth and depth of the content. If I just jump back to my content map, I could literally, we had initiatives at Kaleida, involving 30, 40 people just on length of stay, right? And you had to monitor length of stay and understand who are the outliers and understanding why and that sort of thing. And so each of these subject areas are really basic blocking and tackling, and most organizations have the information, but the challenge really is corralling it and putting it into a tool set that you can consume the information and allow your users who may not be technically proficient to just be able to point and click and understand the numbers. So that's really the spirit of Catalyst, is highly functional with a large set of content. The differentiator here is we're using Oracle Enterprise Edition as a tool set, right? And think in terms of when you buy a Microsoft Office, right? Everybody needs Microsoft Office, but when you buy it, you open up Excel and you get a blank spreadsheet, right? The same is true with BI tools, right? When you buy Cognos, Business Objects, OBIE, you buy the product, but you have to start from scratch. And so what we're really saying here is, here's a template for success. This actually is literally what we used at Kaleida Health and revised and refined over 13 years. It's what they're using now at Hackensack University in New Jersey, and using on a daily basis. So this is proven. It's got all the attributes you need, and the beauty of it is that you can expand on it further, with additional content, etc.